Welcome. I hope you're having a great day. This presentation is on beta-adrenergic antagonists. First, be sure to look at the actions of beta antagonists. If you know these actions, you will know how beta blockers work and many of their side effects. Note that the beta-2 effects may cause hypoglycemia through decreasing glycogenolysis, where normally glycogen is converted to glucose. At the same time, gluconeogenesis in the liver is decreased, causing additional hypoglycemic effects. These effects are more prominent in diabetes type 1. Although not on this table, beta blockers of beta-2 receptors are thought to contribute to the development of hyperglycemia by impairing the release of insulin from the pancreatic beta cells. Interestingly, carvedilol and nebivolol are not associated with the development of hyperglycemia or new onset diabetes. There is some indication that starting on a beta blocker can cause diabetes. Beta blockers inhibit the effects of norepinephrine at the beta receptors and result in a decrease in heart rate and in the force of contraction and constriction of the blood vessels, which ultimately decreases peripheral vascular resistance and decreases afterload. This action depends on the degree of sympathetic activity. Therefore, there's a significant effect on heart rate and contractility during exercise or excitement, but less effect on these variables at rest. The constriction of vascular smooth muscle causes cold peripheries as a side effect. Other effects regulated by the sympathetic nervous system include contraction or relaxation of smooth muscle, including relaxation of the airways, and the release of glucose from the liver. These actions help to explain some of the side effects seen with beta blockers, such as bronchoconstriction and hypoglycemia. The beta-2 effects are more likely to worsen peripheral vasoconstriction or bronchoconstriction, delay recovery from hypoglycemia in type 1 diabetes, and impair exercise performance. Non-selective beta blockers block the beta-1 and beta-2 receptors in the heart, blood vessels, kidneys, and lungs. They produce a fall in blood pressure without reflex tachycardia or reduction in heart rate through a mixture of beta-blocking effects. Non-selective beta-1, beta-2, and alpha blockers are predominantly beta blockers, but also block alpha-adrenergic receptors in blood vessels, causing peripheral vasodilation, which lowers peripheral vascular resistance and reduces the incidence of cold peripheries. The vasodilation is advantageous in heart failure. Non-selective agents with intrinsic sympathomimetic activity have a decrease in resting heart rate and negative inotropic activity and may be less than with other beta blockers. These agents, therefore, may be useful in individuals exhibiting excessive bradycardia with sustained beta blocker therapy. Agents with ISA, or the intrinsic sympathomimetic activity, are not used after myocardial infarctions, as they have not been demonstrated to be beneficial. They may also be less effective than other beta blockers in the management of angina and tachyarrhythmias. The beta blockers with ISA partially antagonize while actually causing a small degree of activation of the beta receptors. Therefore, they will have some beta blocking effects, but not to the degree of beta blockers without ISA. These are commonly used in younger patients or in athletes where heart rates need to elevate, allowing overall increased cardiopulmonary effort in order to compete in sports. Examples of the beta blockers with ISA are pindolol and acebutolol. Now, selective beta blockers competitively block stimulation of beta 1 receptors in cardiac smooth muscle. These drugs produce negative chronotropic, meaning they decrease the heart rate, and negative inotropic, they decrease myocardial contractility. They decrease the rate of SA node discharge and increase recovery time. They also slow conduction through the AV node, causing a decreased heart rate, decreased workload of the heart, and decreased oxygen consumption in the myocardium. Secretion of renin is inhibited at high doses, resulting in decreased response of the renin-angiotensin-aldosterone system. Beta 2 receptors in the bronchial system are also inhibited at higher doses. Selective beta blockers are less likely to produce side effects such as bronchoconstriction or cold peripheries seen with non-selective beta blockers. Here's a table that I created for the indications for the different beta blockers by class. The red X's are those approved by the FDA, and the green X's are those that have proven efficacy through clinical trials. A couple of notes. Atenolol does not have reduced cardiovascular outcomes in hypertension treatment, so you really shouldn't use it for hypertension. The short-acting metoprolol tartrate, can be used post-MI, but not metoprolol succinate, the long-acting one. I did not put that propranolol can be used to treat pheochromocytoma, which is an adrenal tumor, or that acebutolol can be used for ventricular arrhythmias. I also did not indicate that beta blockers can be given for performance anxiety, and I do not mean sexual performance anxiety. I'm talking about public performance, speaking in front of a crowd, or maybe test anxiety. Beta blockers can also be used for the treatment of symptoms of hyperthyroidism. We have previously discussed the role in the treatment of glaucoma. Beta receptors are found all over the body and induce a broad range of physiologic effects. Blockage to these receptors with beta blocker medications can lead to many adverse effects. Common adverse effects of cardioselective, so the ones on the right-hand side of the screen, include bradycardia, decreased exercise capacity, hypotension, atrioventricular nodal block, and heart failure. An additional risk of beta-1 blockers is the masking of hypoglycemia-induced tachycardia in the diabetic patient, which serves as a warning sign of the patient blood glucose levels being too low. On the other side of the chart, fatigue, dizziness, and weakness are reported. Nausea, vomiting, abdominal pain, and constipation are also widely reported. Some patients report sexual dysfunction and erectile dysfunction. Less commonly, bronchospasm presents in patients on beta blockers. Asthmatic patients are at a higher risk. Patients with Raynaud syndrome are also at risk of exacerbation. Beta blockers can induce both hyperglycemia and mask the hemodynamic signs usually seen in hypoglycemia, such as tachycardia, as mentioned previously. Some patients report insomnia, sleep changes, and nightmares while using beta blockers, and this is due to interference with the effects of melatonin. Many of us were taught to avoid beta blockers in these patients with COPD and asthma because of concerns about bronchoconstriction. But cardioselective options like metoprolol, bisoprolol, etc., don't cause more exacerbations or reduce airway function in COPD or asthma, and patients still respond to beta agonists. Plus, evidence continues to grow that beta blockers in general may actually decrease exacerbations and improve survival in COPD patients, probably by treating the coexisting cardiovascular disease. Don't hesitate to give most COPD and asthma patients a selective beta blocker, especially in cases where they improve outcomes, such as post-MI or for heart failure with reduced ejection fraction. But continue to lean away from non-selective agents, carvedilol, propranolol, etc. in COPD. There's not much evidence of safety. And avoid non-selective beta blockers entirely in asthma. There's evidence bronchospasm or exacerbations can occur. Beta blockers vary in their lipid solubility. Those that are highly soluble, such as propranolol, are easily absorbed across the GI tract and are bound to plasma proteins. I should say they're highly bound to plasma proteins. This results in a high distribution to body tissue, which may increase the incidence of side effects, such as bronchospasm. Highly soluble beta blockers will also cross the blood-brain barrier, which can lead to CNS side effects, such as sleep disturbances. Less lipid-soluble beta blockers, such as atenolol, are not as well absorbed, are not highly bound to plasma proteins, and do not cross the blood-brain barrier, resulting in a lower incidence of CNS effects. In general, they also have a longer half-life than the highly lipid-soluble beta blockers, which means they are effective longer and can be given less frequently. The lipid solubility is listed on your handout that compares oral beta blockers from prescriber's letter. Non-selective beta blockers should be avoided. Thank you for your time and attention. I hope you have enjoyed this presentation.